Good evening. Finally, we'd like to start. I hereby want to welcome you to this great event and with great speakers and even greater topics. I want to kick things off with a little introduction of ourselves. Not because I'm narcissistic or very much in love with XA and stuff, but maybe I can pick interest in joining together with us or with Neuron AI for some cooperations, or if you just want to be part of a cool crew. This event today was made possible by two groups. Firstly, we've got Neuron AI, from which you'll hear a few more words from David in a few minutes, and also XA, which I'm here to present today. Who are we? We are a science organization with a very simple credo. We love to learn and we love to share this knowledge. We started out as a student group who met like regularly, and we realized that each one of us had special skills or special interests, and we really benefited a lot by this exchange. So from this perspective, we just wanted to expand this and make it broader and wider and reach more people. What do we do? We make these sort of events. This isn't our first talk. We also make a lot of workshops and just stay in contact with each other, exchange knowledge, and mostly have a good time. We are always interested in making cool events like this. So if you, for example, have a great idea for a talk or maybe a workshop, you can always reach out to us and get in contact with any of us, and we maybe find a way to get things done, maybe get a room, maybe get a workshop location, maybe even get equipment. We already met several talks like this, like, I don't know if any one of you has been to Discovering Artificial Intelligence, Quantum Computing, or the Cybersecurity talk. As I already said, another big part is organizing workshops, which is very much a more hands-on experience on this sort of exchange, and we are always open for new skills and people who want to share these. Lastly, we are of course also very much interested in networking in general. As I said, getting together with interesting new people, cool guys, we are in contact with several companies. So if you want to have a look into that, reach out to us as well. And currently we are partnered with 5Square, who's a major sponsor for this event today, and we are very grateful for having him. So I'm going to hand over to David to talk a little about Neuron AI.
Thank you. So hi, I'm David. Welcome to our event. I have the pleasure of now quickly introducing Neuron AI to you guys. We are a student initiative here in Linz. We are motivated students that have a special interest in the topics surrounding artificial intelligence. We are structured in departments so we can efficiently work. And what is it we do? We primarily organize events like challenges where we test our AI capabilities, or also invite other people to do so. We try to keep up with latest research, and we also try to organize events so experts in various fields can show what they are researching on. You can find us at our website, neuron-ai.at, neuron-ai.at. Yeah, because Neuron AI was taken, unfortunately, or on the socials. But so follow us to keep up to date with our latest infos. And now I hope you all enjoy the evening and have fun.
So we're going to start off with Philipp Moser, who's a specialist from RISC, and yeah, just gonna.
Hello, hello. Okay. Okay. So, good afternoon, everybody. My name is Philipp. I'm a senior researcher at the RISC Software GmbH, and I have the pleasure to talk a little bit about deep learning applications in healthcare. Well, this is a very broad topic and a very broad title, so I want to be a little bit more specific. The topic will be how to generate patient models using artificial intelligence. I will talk a little bit about what patient models are, how we can create them, what annotation means, what challenges do we face using annotation. And then at the end, I thought it might be interesting to really share a hands-on use case that we have been researching very recently and give you a practical hands-on feeling of how to tackle medical image analysis problems using AI. So you might think, why is Philipp actually interested in that stuff? The RISC Software GmbH is an extra university research organization in Hagenberg. We have 4 departments, and one of them is the medical informatics department. We have a broad cooperation portfolio with various national and international partners. And I said we are an extra university research organization, so the JKU actually is a major shareholder. So we are technically a GmbH, but still we see us more as a research organization. The topics that we cover in the medical informatics department range from image analysis and segmentation, which will be the main part of the talk today. We are also concerned with modeling and simulation topics. So you can see here, for example, some blood flows flowing through a real patient aneurysm, and you can detect certain risk factors of this aneurysm to rupture. We are also involved in a big project where we are building a virtual training platform for neurosurgeons, which you can see here on the right side. So the surgeon can, in a virtual reality world, practice and train interventions so that, especially for young doctors, these cases can be trained on this simulator. And the last topic that we're concerned with is data analysis and prediction models. So all kinds of time series data, but also tabular data like blood parameters, go into some prediction models, for example, to do some mortality predictions. So now let's talk about patient models and what I actually mean by that. It's basically just some digital representation of a patient, or at least of some parts of it that are interested in a specific use case. The very left one is an abdominal aorta, for example, which we extracted from MR images. So in the project EndoPredictor, we had patients that had some problems with this aorta, and the intervention was that a doctor put in a stent, this blue thing that is outside of the vessel, which basically helps to stabilize it and cures the disease to some extent. And the model now was extracted from images and then was used further down in blood flow simulations, and we created some sort of a risk assessment platform to actually judge, somehow standardized, if the operation was successful or maybe not. Another patient model you can see here in the middle is this surgery simulator, which I mentioned before, where we combine different kinds of image modalities to create a head model that includes gray matter, white matter, the scalp, the skin, but also the vessels. And on the right side, this is an image that is concerned with the bone structure of a head. So that was a project in combination with the company CRDS, which produced certain kinds of instruments for operations in the face if you have some disease or some accident. And they are always having CT images which they need to segment. So basically say, okay, this is the lower part, this is the upper part, those are the teeth. And the idea was, can we not train some models to actually do this automatically? That would be probably more efficient. So the first step when you want to create one of these models that I've shown you before is you need certain images. In medical domain, a lot of stuff happens with the basis of images. And the most common ones, you have probably heard of them, are MR images and CT images. And a second thing that you need are annotations, or also called segmentation. So you need to have a label assigned to every kind of pixel that tells you, okay, this is now an aorta pixel, this would be a red pixel, or a blue pixel, which would be this stent, or which is background and which is not interesting to us. And then we can take these segmentations, do some volume rendering, but also meshing and volumetric meshing, and then use this patient model further down to do the blood simulation, as I've shown you before. In many cases, we need to combine image modalities because in a CT, you see different things than in an MR image. In a CT image, for example, they are very good in showing you the skull. So the bone tissue is very visible, as you can see here on the top, the CTA one. Bones are not that visible in MR images, and MR images, on the other hand, are much more powerful when it comes to soft tissue. And there are also other techniques that allow you to identify vessels very, very good. And you can imagine that if a patient has all these kinds of image modalities that may have been taken at different time points, at different hospitals, you not only have to create all these segmentations from the image, but also somehow align them that they at the end fit perfectly and create this sub-millimeter precision patient model. Now, how can we create these annotation masks that I've shown you before? And the most obvious one would be you take a doctor, sit him in front of a computer and tell him mark every voxel that belongs to the aorta. So it involves usually some trained professional. They are typically highly paid, so it is a very costly endeavor to do that. But also, every doctor or every trained professional has a certain type of annotating, because some are more conservative and would draw maybe the region a little bit larger, and other ones maybe are a little bit strict and are very precise. So with maybe an automated method, you can maybe achieve some more standardized or objective segmentations and reduce this inter-rater bias. The next approach if we go down this list of automation, would be some semi-automatic approach, which says, okay, I need some human intervention, but still I have some elements that help me to automatize this procedure. And an obvious thing would be to have somebody sitting in front of the computer, and if you want to segment this aorta, to click inside the aorta and then do some things like region growing, for example, which looks in the surrounding pixels, and pixels that somehow look the same as the seed, and from there grow the region much larger. So this is somehow automated, but still you need somebody to sit there and find the seed values. Or in CT images, what is very common is thresholding. So you just say, okay, every pixel that is above a certain intensity belongs to bone, and everything that is below some certain intensity is not a bone. And then the doctor can move the slider back and forth and then find a segmentation where he is happy. But the most convenient one would be to have a pipeline that is fully automated, where you don't need any human anymore, and everything is done automatically. There are two approaches that you can use, an AI-based and non-AI-based approach. Computer vision is around since many, many years, way before AI was here. So there are also some powerful tools that do not rely on artificial intelligence. But the main topic that I would like to mention today are these learning-based methods. When I talk about learning-based methods, there's a variety of techniques that you can use. Probably you have heard and maybe even experimented with some of them. It always depends on how many labeled data do you have. Do you have no labeled data, or do you have a huge amount of labeled data? For example, if all the data is labeled, you can use some very powerful tools in the domain of supervised learning. And the use case that I want to show you afterwards is using supervised classification algorithms. So now that you have a grasp feeling of what a patient model is, I would like to dive into this use case that I would like to present and give you a hands-on feeling of how to tackle such a problem. So the task is, I give you an MR image like this, and I want you to segment the circle of Willis structure, which is a cerebral brain structure. This is an important structure because many aneurysms and many diseases are located at these regions. So neurosurgeons are very interested in this region. You can see here how it looks like, why it's called circle of Willis, because of this circlish structure, and where approximately it is located in the brain. That is a topic I'm presenting it not only because to show you how such an endeavor works, but a colleague of mine just recently also presented this work at an international conference. Now, if you are familiar a little bit with medical imaging, you might know that when I talk about MR images, this is not just one technique. There are many kinds of MR techniques that you can use to acquire an image. And depending on which techniques you use, vessels will be more or less visible. So on top, you have an angiographic scan, a time-of-flight MRA scan. And here you can clearly see in white, very bright, that the vessels are very clearly segmented or visible, distinguishable from the rest of the image. While when you look on the lower part, these are conventional MR images that do not have this angiographic feature, and vessels do not appear bright. So they somehow look like the rest of the brain, or at least very dark, and it's very hard for a human to find vessels in such an image. And now the task was in cooperation with the Kepler Klinikum, and from them we had such non-angiographic scans here on the left side. These are 3 specific MR sequences, T1 weighted, T2 and proton density weighted images, which all look different, but all of them share the fact that vessels are not very bright. So in all of them it's pretty difficult to find this circle of Willis structure. And what we want to do is to establish an AI model that somehow predicts the circle of Willis structure, so basically find this very nice colored circlish segmentation in these images. So what do we do? The first thing in all of these endeavors is to create an appropriate training data set. And if you have enough training data, that's fine, but if not, you have to create them somehow. And typically, if you don't have enough data, you look on the internet if there are some publicly available data sets. There are many data sets from brain tumors to whatever you can imagine. Some research groups worldwide have put publicly available data online, which you can use to train and build your models. And one of them is from the Imperial College London. It's the ICSI data set. They have 600 subjects included. And for every subject, they have these T1, T2, and proton-weighted density images, which we also have from the Kepler Klinikum. But they also offer these time-of-flight MRA images, which you can see again. The vessels are very bright. So the second step is we take those time-of-flight images and run them through a conventional image processing pipeline, which is a combination of different filters, atlases, and morphological thresholding, so that at the end we end up with a very nice annotated vasculature for all of these 600 patients. And the third step now is, since in the ICSI dataset all the images are perfectly aligned, we can take the segmentation map that we have for the time of flight image and just transfer them to all the other images. So what we have created now is a perfectly fine supervised learning framework where we have 600 subjects, and for all of them we have the input images and the appropriate segmentation masks. And then we use some conventional, very popular methods to train a model and to select a model. In that case, it's a convolutional neural network. For all of you who have been researching or working in the field of image-based learning algorithms, convolution networks are very popular. And in this case, we use a 3D unit version because the images are, of course, volumetric, so it's a 3D volume. And so we input on the left side into the network those T1, T2, and proton density weighted images. And what comes out on the right side are the segmentation masks. And to be more specific, maybe somebody has already used this framework, is the NN unit framework. It's a framework that is released by the Deutsche Krebsforschungszentrum, and it achieved state-of-the-art results in a variety of medical image segmentation tasks. So here on the bottom you can see, for example, on the right side, it has been employed for lung cancer detection, in CT images, in cell classifications in the middle, or just generally to segment various kinds of organs. What is very nice about the NN unit is that it performs a lot of the hyperparameter optimization for you. So it looks at the data first, it does some statistical analysis on it, and then figures out what would be a good configuration of the network for this kind of data, and then starts with the training. So as a user, you just start the training and don't have to worry too much about tuning and modifying the network itself. We trained the network on one of our hardware in Hagenberg. It took 30 hours to train. On a cluster, it would have been probably much faster. Here you can see some nice results. So the first column is the ground truth. So that is what you're looking for. These are results for one specific test patient. And the images in the box are the predictions on one of these non-angiographic scans. And just from looking at them, you can somehow qualitatively see they look rather similar. Of course, you will find differences, especially in the very fine parts of the vessel, because the structures get very small and the network struggles the thinner the vessels get. But overall, we were quite satisfied, and a common metrics to evaluate classifications is the Dice coefficient, which was also in a quite decent range here. So now when we go back, before there was this question mark over here, we found our question mark. We trained a deep learning model on some publicly available data set and can now use this trained model and input the images that we got from the Kepler Klinikum and then create these segmentation masks. And now you can say, okay, what do I do with these segmentation masks? Neurosurgeons will have a look at them and will assess and make statistical comparisons if you can see any kind of obvious malignancies when it comes to outcome. So they correlate outcome with geometry, so to say. So just to conclude, some final remarks. What I hope I could show you is that patient models are some kind of a digital representation, or at least parts of a patient. They appear in a variety of fields, and usually you extract them from some image modality. AI methods are today a very popular choice for it because they achieved very promising results in a variety of tasks. They help in automating things that reduces cost, workforce, and maybe also helps standardizing certain assessments. But of course, the good old Büchse der Pandora is that if everything is done by by machines. The question arises, who is actually responsible if something goes wrong? So this is an ongoing discussions. Who is responsible? Who is it? The manufacturer? Is it the researcher? Is it still the doctor? It's a huge discussion that we as a society need to take. But still, I think we cannot hide all these very promising results that we get from AI in healthcare applications. And that's it from my part. I'm happy to answer any questions if you have, or also afterwards, like you wish. Thank you. Okay.
No questions whatsoever to such an interesting topic. Come on, guys. Yes, the first one, please.
Is it possible to use this image recognition with the blood parameters in such a way that AI can recognize it not only to the image recognition but also to the blood parameters? For example, if some proteins or anything is there.
You can combine it. The term would be fusion models somehow, because you somehow need to compress the information that you get from images with the information that you get from some laboratory values. Of course, they are very differently structured. I mean, an image is a 3D volume, while the others is a table or so. And typically what you would do is you would have encoding for each of these domains, and then fuse them in feature space and then expand it to some result. We haven't done it here, but there are many applications where they combine image with genomics, with blood parameters, and whatever you have available, or what you think that can help.
Okay, so this can be done for precise diagnostics?
It's an ongoing research, yeah. I don't think there's any actual application to it, but it's a huge research topic, yeah.
Thank you.
Where did the ground truth come from? Did some guy annotate it manually, or because?
In this case, we generated the ground truth with this conventional processing pipeline. So
Okay.
in many
So another model.
yes, but the model is not somehow a learned or trained model. You're right, there was no doctor that at the end assessed the ground truth generation, just a few examples of it. But in that case, the ground truth was generated by us by non-AI methods.
Do AI models that are trained on data based on rule-based systems, do they have a chance of outperforming these rule-based systems? So is there an advantage of this AI system as opposed to the rule-based system?
I don't have too much.
You should repeat the questions on the recording.
I'm not an AI student, I'm sorry.
So my question, maybe also for the last question, was how the ground truth was generated, and it's on a rule-based system, kind of. And I was curious if there are advantages of using the AI system, like a neural system, as opposed to the rule-based system that was used for generating the ground truth.
Well, the ground truth. Sorry. The ground truth we couldn't generate with a with an AI-based system, because that would require some doctors to have drawn all the segmentation on these time-of-flight images. I'm not too much of an expert with rule-based systems, to be honest. I've never worked with them.
I'm more curious, like the system that was used to generate the ground truth.
Yep.
Yeah. So is this expected to perform equally well as the AI system, the unit that you trained? Or
Yes, but they are applied to very different tasks.
Okay.
So the rule-based system was used to create the segmentations from images where the vessels are very, very obvious.
Okay.
They are very bright, so it's quite easy. And the ground truth that we get generated then from this rule-based system was then used as a classification prediction in the AI model.
Okay, thank you. I understood where.
Yeah.
Yeah. All right.
One more question. How generalizable would you say is the model? Like if you were to apply it on images from, say, another clinic, or if the images were like slightly rotated or just different in one way or another?
Rotation is typically not a big problem because these networks are very powerful when it comes to some sort of shift or rotation. Actually, they are trained on shifted and because you introduce certain variety in your data set, so that is a good thing. With respect to differences in scanners or sites, if somehow the sequence protocol is roughly the same, so if the images look roughly the same as they did in the training set, even if they come from Japan or somewhere else, it's no problem. We test, for example, we evaluated the problem, of course, on the ICSI data set, which is from this London clinic, but also evaluated it on data from the Kepler Clinicum, which also worked pretty fine. Yeah.
All right. One more question. All right, then thank you for this talk. We will now move on to our next talk about brain-computer interfaces. The company GTEC is from a small village called Schindelberg near Neuhofen an der Krems, and they are manufacturing the brain-computer interfaces there since already 25 years. And now, please welcome the CEO, Christoph Gruber.
It's okay?
Does it work?
Hello? Okay, thank you very much. So my name is Christoph, and we are developing for 25 years brain-computer interface and neurotechnology. So I'm coming from Schindelberg. We have 1,000 people, but the good thing is we don't have traffic lights, and we have parking slots. So in Schindelberg we are doing international sales and also research projects in Graz. This is where we are coming from University of Technology in Graz. So we are spin-off from there. We are doing all the hardware. And we have also offices in New York, in Albany, in Barcelona, in Vancouver, Hong Kong, Sapporo. And actually on Monday we started also in Colombia for international sales. So we are active in about 15 different research projects. They are mostly with the European Union, but we also work with Canada, USA, and Japan, and many other nations. And these projects have all to do with brain-computer interfacing. In Coma 8, we use it, for example, for coma patients to figure out if they have some context awareness. And this is very useful because these coma patients are just lying there and you get no idea if they're understanding you. And with our BCI technology, we know that after a few seconds. And in RecoverX-LAG, we use BCI technology as a neurorehabilitation procedure for stroke patients and multiple sclerosis patients. And this is also what we are doing in Schindelberg, for example. So we already treated 30,000 times stroke and multiple sclerosis patients in Schindelberg. And it's pretty funny if they're coming from everywhere to Schindelberg. And this is actually from Linz. It's from the Ars Electronica Festival a couple of years ago. So we worked here with an artist, Dragan Ilic, who is working in New York. And he hooked up our brain-computer interface with a KUKA robot. Then he fixed many colors on the robot, and with the brain-computer interface, visitors could actually contribute to the painting. And after Ars Electronica, they sold it for £25,000 in London. This is a very nice piece of artwork. So what is a brain-computer interface? Basically, you need a student, a subject, a patient, and we are measuring EEG on the surface, so we put electrodes on the scalp, but we can also implant electrodes. For that, we need a neurosurgeon. And then we don't work with students anymore. We take epilepsy or tumor patients, and the BCI system gives us a control signal so that we can control external devices in real time. And very important is the feedback loop. So we have to see or we have to feel what we are controlling in order to get better. And this is how a brain-computer interface looks nowadays. This is our Unicorn Hybrid Black. It's costing around 990 euros. So many years ago it was costing more like 50,000 euros. Just to give you an idea, basically you press the start button on the back and then it's already transmitting high quality EEG data and we can already run BCI experiments. So this unit is just another one. It has, for example, 64 channels overlaying the whole scalp. And then we can just get much more information of the human brain. And this is depending on the application, what we want to do actually. And here's one of our computer scientists, Martin, doing some exercises. And this shows you or gives you an idea how EEG signals look like and what's important when you're doing EEG recordings. So Martin is wearing our wireless BCI system. And at the moment he's running, on the left-hand side, you can see the data visualization of 8 channels. So each channel is coming from one electrode distributed over the whole brain. And then you can see that we get artifacts in the data when he's moving. This is basically muscle activity and eye movements and motion artifacts because the cables are moving. And this is problematic for interpreting EEG data. And on the right-hand side, you can see actually the output of our wireless EEG headset. So we do a dramatically high oversampling. We do a very steep anti-aliasing filter and some adaptive filtering. And the output of the BCI system is actually very clean. And this is super essential when you're working, for example, with patients. So in coma patients, you get maybe 5-minute slots when they are awake. And then you have to do your assessment as quick as possible because afterwards they are drifting away again. And if you're losing maybe 3 minutes out of 5 minutes, then you're wasting the patient's time and also the physician's time. And now with the handstand, you can see there's a lot of muscle activity overlaying the brain readings, the EEG signal. And that's the problem when people are doing EEG recordings. Very often they don't care about data quality, but it's super essential because otherwise you are not extracting anything useful. And now he's doing a backflip, so watch careful. It just takes 100 milliseconds. Almost there. So now watch careful. So on the left-hand side, you can see the super large artifact. On the right-hand side, you can see the clean output of the EEG system. And this is just changing everything in the EEG domain, because with such a headset, you can use EEG in many parts of your life, because even doing a backflip, we are getting clean data. And this is what we are using for Recoverix. This is our medical product that we developed in Schiedlberg. In this case, we are treating stroke patients. Here you can see a patient with the EEG headsets on the head. We have electrodes over the sensory motor cortex, so we are decoding motor movements, left hand, right hand, foot movement. And in front of him there's an avatar, and this avatar is lifting the left hand. This is the instruction for the patient to do exactly the same. So he's just imagining the movement. The brain-computer interface picks it up that the left hand representation area is active, and then we trigger a functional electrical stimulation of the left hand. And this pairs actually cognitive processes with motor behavior again. So here you can see how the treatment looks like. He imagines now the left hand movement. BCI system picks it up, and in real time we can stimulate the left hand. This repeated 240 times in one therapy session. It's randomized between left and right. So the right hand is more interesting because it's the Barretic hand. And now he imagines the right hand movement. It's stimulated again. You can still see the spasticity in the index finger. So the finger is still stiff because the brain is damaged and they cannot correctly use the arms and the hand. And we are repeating this 25 times. And afterwards, stroke and multiple sclerosis patients are much better. And this even works 10, 20 or 30 years after the stroke. Normally, neurologists tell every patient after 1 year there's no improvement anymore, but this is just not the case. And this is another application. This is much more invasive. In this case, we work together with neurosurgeons. In this case, with Dr. Kamada from Japan. And he implanted an ECOG grid directly on the cortex. This is a little array of platinum electrodes. In this case, we implanted 256 of these electrodes. Then you get 256 cables coming out of the scalp, and that's connected to the brain-computer interface. And I can also show you how this Cortex-U system is actually analyzing brain activity. So in this case, the epilepsy patient is just sitting there and not doing anything. On the left-hand side, you can see an ECOG recording of 64 channels. In this case, it's overlaying important areas of the brain. So here in this visualization, you can see the different arrays where we are recording from. The small dots are the electrodes. And now he gets the instruction to stick in and out the tongue, so he's just moving the tongue. And first of all, we get here an activation of the temporal base. This is the face-sensitive region. So if you are seeing somebody, this region gets activated. And afterwards, we find here the tongue region. So we are doing a so-called high gamma mapping. We are analyzing data between 80 and 200 hertz. In the EEG data, that's called high gamma activity, and it's very precise, so the spatial resolution is very high. And now he's just listening to a Japanese story, like Dr. Jones drove to New York. He's just listening, and first of all, we get an activation of the loudspeaker sensitive region of the brain. So if you see a loudspeaker, this region is activated. And afterwards, the auditory cortex and Wernicke's area, because he understood what he was hearing. Then he solves Rubik's Cube. So first of all, we get the shape-sensitive region, which is here, because it's a cube. Afterwards, we get the color-sensitive region, it's here. And at the end, we get the finger region, because he's moving the fingers. And this is very important information for a neurosurgeon, because if he resects, for example, this region here, this has the consequence that the patient cannot identify faces anymore. This means all your friends are not known anymore, and this is, of course, very bad. Before Cortex-U existed, neurosurgeons were removing this part of the brain here, with the bad consequence that they didn't recognize the wife and the children anymore. So really bad. Now they can preserve it because we have the BCI system for mapping activity. Now I'm going to a little bit more funny application. This is our Unicorn Blondie check. It's a politically incorrect name for a picture ranking system. So in this case, we are showing different images for 100 milliseconds, and the user is just observing you. So you don't have to do anything. You're just watching, and in the background, the BCI system is extracting which image is the most important one for your brain. It takes a few seconds, and you see the blonde girl appears first. And then we have some other human beings. Then it gets more abstract flowers. And the least important one is the landscape for this human being. And we tested it first with male university students, and always the blonde girls were in first position, so we called it Blondie check. But it became pretty funny because we mixed also pictures of the mother and the girlfriend into the picture set, and suddenly the mother appeared before the girlfriend. and so then it gets embarrassing. So when I did it, I made sure my wife is not inside, but my children were. But you can also use it for more serious applications. So you can also test logos. If you're developing a logo, you can check out which logo works for human beings, and so on. And this principle led us also to a connection of the brain-computer interface with ChatGPT. So I don't have to explain what this is, but this is the pipeline that we are using. So first of all, we have the EEG, the brain-computer interface acquisition device. Then we use MATLAB and Simulink for extracting some features. We move it into C# to create JavaScripts that can speak with ChatGPT. And here's a video of such a recording. So this is Sebastian, one of our PhD students, who is also supervised here from the university. And Sebastian is measuring from 80 EEG channels. You can see he's producing now some artifacts by clenching teeth. This is just testing that all the channels are nicely working. And then he is doing different things like relaxing now. So we have seen the alpha activity, that's a 10 hertz oscillation. And this shows that the brain is relaxed. So when you close your eyes, alpha appears. And then we are also estimating different features. So there are different oscillations. They are called delta, theta, alpha, beta, and gamma. These are different frequency ranges of the EEG, and they have different meaning. And then Sebastian opens the eyes again. And at the end of the video, he is also solving a Rubik's Cube. And every 30 seconds, we are transmitting all these features to ChatGPT. And then ChatGPT is actually analyzing the data, the meaning of the data. Because when you're just looking at the EEG data, it doesn't tell you anything. It looks like noise. So you need some feature extraction and more intelligence to learn something of it. Now you can see he's solving a Rubik's Cube, so he is cognitively engaged. And then ChatGPT gives us again an answer. So I highlighted this a little bit. So we formulated in JavaScript a question. I have acquired some EEG data for 30 seconds. I've calculated some biomarkers. From this data, I have acquired a delta data ratio of 2.2, a data alpha ratio of 2.3, and a beta ratio of 2.1. Can you interpret the data? Then ChatGPT interprets it. The overall message is this data suggests that the EEG data is heavily elevated alpha activity. This may indicate a calm and relaxed mental state. So it's correct. And this is when he was actually doing Rubik's Cube. So we put in all the parameters again. And at the end, he's saying, in general, these results suggest that the EEG data is dominated by high frequency components, shows arousal. So also in this case, he did some active processing. And with this pipeline, we can actually put a lot of EEG data into ChatGPT and ask the network to interpret it. And this is very nice. Also of the RecoverX data that I showed you before, just in Heidelberg, we acquired 30,000 data sets. And we're also using big data learning to analyze the data. And then we figured out, for example, with only 5 minutes of resting state EEG data, we know how much a stroke patient will improve when he's doing 25 RecoverX treatments. And this is very useful, especially for social security systems, because if we tell them before, after 5 minutes of EEG recordings, how much they improve, they are willing to pay for RecoverX. And this is already implemented in Austria, so social security already pays part of the treatment. And in this case, for this massive amount of data, AI actually, or deep learning, is very useful. And at Ars Electronica this year, we also showed it in the exhibition, this connection of the brain-computer interface with ChatGPT. But of course, at Ars Electronica, we wanted to do some more advanced. So we hooked it up to DALI. So in this case, we have the same processing pipeline, but ChatGPT is sending the result to DALI. And here you can, for example, see the result of a journalist who tested it out at the festival. And then he made also a nice blog article about the experiment. He called it "My Brain on Fire." And this is also very nice because the EEG data that looks more or less like noise can be interpreted by ChatGPT and DALI into artwork. And otherwise this would be really difficult to translate. And this is also useful for other applications. In this case, we work together with Anouk Wipprecht. She's a fashion designer from the Netherlands. And in this case, we developed a unicorn headband. So it's a 4-channel, pretty cheap EEG device costing around 350 euros. And this headband is analyzing cognitive workload. And we are mapping this to these hyperpixels. So in this case, we have the brain-computer interface. We are sending the data to a computer. We are extracting from the EEG data cognitive workload. And via Wi-Fi, we communicate with the 8 hyperpixels via a Raspberry Pi. And then we project it in Unity in eye. And the eye opened and closed depending on the workload of the user. And here I have also a video that's demonstrating how this works in real time. So Anouk is well known for these 3D printed dresses. She's doing this forever for all big companies like Intel and Mercedes. And this was also shown at Ars Electronica this year. These are the hyperpixels. Then we created in Unity the eye, which can actually turn around and move and open and close. And the brain-computer interface is calibrated for a couple of minutes on the personal EEG data, and then we can extract the workload from 0 to 100. And this is actually then transmitted to the hyperpixels. And this is a nice way of visualizing how much workload you have. So imagine your professor in front of you, and then you could directly visualize if he's keeping you engaged or if you're completely bored. But you can also use it to visualize, for example, emotions or any other parameters you want to show. Yeah. And at the moment, she is showing it in Japan, in Tokyo, at an exhibition. How I'm doing time-wise? Then I have 2 minutes. So here's another example. So I showed you up to now recordings with not so many channels, but recently we developed also a 1024 channel ultra high density EEG system. And you have to look at the dark electrodes here. This is the clinical standard that they are doing worldwide in the hospital. So they use 19 EEG electrodes to extract all the information that you want to have from epilepsy, tumor, stroke patients, and so ever. With the 1024 channel system, you have to watch at the small circle. So every circle is one single electrode. So the density is just much higher. And then we work together with the institute in South Korea, KAIST, because they have so many monks, and monks don't have hair. So it was very easy to assemble this Pangolin system because it only works on the shaved head. But we get a very high spatial resolution, and then we were asking these guys to move single fingers, and we tried to decode it with the EEG signal. So normally for that you need an implant. So the neurosurgeon has to put grids directly on the motor cortex, and then you get enough resolution. So up to date, it was just completely impossible with an EEG system. So in this experiment, people moved a couple of times the thumb, the index finger, and so on. And then we tried to map where the fingers are located. And here you can see the index fingers, for example, in orange, the middle finger is in yellow, the thumb is in red, and so on. So we can actually very nicely see the different fingers with this 1024 channel system. And this slide is really interesting because here you can see the clinical standard. So this gray electrode is pretty big. So it's more or less overlaying 9 smaller electrodes. And you can imagine if one electrode is here in the hospital and another one is here, then you would never be able to distinguish single fingers from each other. So it's just impossible because the spatial resolution is not good enough. And if I'm now meeting a PhD student, then I suggest them take 5 neuroscience papers that you like, replicate it with the Pangolin system, and your papers are done. And whatever you find has much more spatial resolution and is new. And this is actually the case. Every single study can now be redone because the resolution is so much better. And this is my last slide. We are organizing again a BCI and Neurotechnology Spring School next year. It's from April to May. So this year we had almost 16,000 attendees from 113 countries of the world. And we always attach a hackathon where people are using BCI technology and they come up with new applications. And this is also a very nice setup for this group here because we have also AI teams in the hackathon. And basically, we could organize BCI systems, and then you could record data. And with the AI, you can try to extract more information, and it's an international challenge. We have also some awards and prize money. But it's also very nice to get in contact with students from Stanford and Harvard and many other universities and to meet future supervisors or professors. So it's a very nice event, and it's also free, so everybody can participate. Thank you very much.
Thank you for this amazing talk and presenting to us such a nice acrobatic performance with the brain interpretation. Are there any questions?
How much data is transferred per second? I mean, it will depend on how many channels and so on, but what are the ranges with brain-computer interfaces?
For the EEG data, normally we use 256 hertz per channel, 24 bits, so we transmit float 32. And if you use 8 channels, it's not so much. If you use 1024 channels, it's already something. For the ECOG data, we use up to 38 kilohertz per channel. So if you're recording 1000 channel times 38 kilohertz, it's a lot.
So how many megabytes or gigabytes will it be?
So for a Recoverix treatment, which lasts 45 minutes, 16 EEG channels, it's about 50 megabytes. For an ECOG recording with 1024 channels, it's a couple of gigabytes after a few minutes.
Okay, thank you.
At the end, you talked a lot about how you were able to improve the spatial resolution with like electrodes placed on the skull compared to implants. And my question is, how low is it theoretically possible to get with only placing electrodes on the skull, at least on the surface? Is it ever possible to reach spatial resolution that's close to like 1 neuron, what is possible with implants? Or is it just impossible?
So up to now we have 8 millimeters center to center distance. But the main problem is that the brain is about 25 millimeters away from the surface. So with the ECOG implant, you're directly on the surface, but you're just recording from the surface. And then there are also depth electrodes, so needles more or less that you can stick into the brain. And then you can also record from deeper structures. So this is not possible on the surface, but you can also find ways to decoding information from deeper structures. The amygdala, for example, is decoding emotions. It's much deeper in the brain, so you would never see something clearly in the EEG. But there are guys from Israel, for example, who used fMRI to figure out when the amygdala is active, and then they looked for biomarkers in the EEG which are decoding amygdala activation. So they learned how it looks like, and now they just look for these biomarkers in the EEG, and then they can interpret deeper structures. So there are ways of doing that.
Thank you.
We heard a lot of interesting things about measuring brain activity, but did you already do some research vice versa, so to activate via electrodes or so the brain to stimulate a certain activity of the body?
So I showed you one example. Recoverix is stimulating the periphery, so we are measuring in the brain and stimulate somewhere the muscles, but we are also doing the opposite, so we stimulate into the brain. This is a standard procedure that neurologists and neurosurgeons are doing. And this is also the golden standard for mapping important centers of the brain. In this way, you are just stimulating every single pair of the implanted electrodes, 1 versus 2, 1 versus 3, and then you observe if the patient shows any movements, has any symptoms. So if you are hitting the finger region, then your finger will move. And the neurosurgeon writes down this was channel 17, it's the finger region. This procedure takes about 2 days per patient. It's also horrible because you're sitting there with open brain, somebody is stimulating your brain. And with CortecQ, we can do it in 4 minutes compared to 2 days. And research in this area is called neuromodulation. So we are also providing a platform for many researchers and neurologists for doing that. Parkinson is a good example. In this case, they are measuring on the prefrontal cortex. If they find beta activation, that's a biomarker for tremor, then on demand they stimulate into the thalamus. This is just electrical stimulation. It's about 1 to 10 milliamps, and then the tremor suddenly stops. And there's a lot of research now ongoing for depression. So you can also do the same principle in neuromodulation for depression patients. So you look for biomarkers in certain brain regions and then you stimulate into other centers. And this helps a lot for depressed people.
Thank you.
So I am an outsider to AI, so I don't know how trivial this fact is to everybody, but you showed the pipeline where JavaScript communicated with ChatGPT, and then you showed the conversation between the two. And my question is, do these two programs communicate via natural language or in any other way? Because the image of the text you've shown, was this just for us to read, or do they communicate really in this way?
This was really the text message that we put in. That's the reason why we used JavaScript, just to create the text. And then we got the response from ChatGPT.
Okay, so am I right to say these programs you use while computing and interpreting the values do communicate via natural languages? Mm-hmm. Okay, thanks.
So I would have kind of a follow-up question on this. So as an AI student, I'm kind of skeptical of having language models trained on the entirety of the internet being capable of judging brain signals totally. Have you seen great performances on the correctness, or have you somehow found a method to test or to reliably test an open, non-specific model like ChatGPT which was trained on many other tasks, and which is a language model based on tokens which are not just solely focused on brain data? Have you found some concrete performance metrics on the reliability of
no, we implemented just a pipeline, especially for the hackathons that we are organizing, because so many people are interested. And we give the pipeline now in the hackathons to people, and they're working on different applications. And so we showed that the pipeline works, but we are not evaluating how good ChatGPT is, because I share the same critic.
Yeah, it makes sense that it's
and at the moment we also don't need it, because we have the deep learning, we have the assessments that we do with our patients, so you need much more information for interpreting the data. But in this case it was correct, and I'm pretty sure the quality will increase over time, because there's just much more data coming in, and it could be a useful tool.
All right, thanks.
First of all, thank you for the very interesting presentation. I have one question. We just learned that you can measure the electronic signals from the surface of the head, but if you want to stimulate it, is it also possible from the surface, or is there anything else needed, like an implant?
Depending on what you want to do. So what we build are DDCS stimulators. In this case, you apply direct current to the brain. And this done to enhance or to inhibit cortical functions. It's used, for example, in coma patients as a rehabilitation tool. But you can also try to inhibit or enhance motor functions and so on. So this is the easiest technique. It's like connecting a battery to the brain, and you stimulate for 20 minutes. Much more complicated is transcranial magnetic stimulation. In this case, you're using a big coil. Then you are applying a big magnetic pulse for a very short moment. And then you can target different regions. So if you target, for example, the hand region on the motor cortex, then your hand suddenly moves. It's a kind of magic, because you're just sitting there, you're not planning the hand movement, and your body moves. This is used also for many patients nowadays in the US. It got recently FDA cleared. And for depression, for example, it's now a standard therapy in the US. And then for the cortical stimulation that I explained before, this is done invasively, because you need a good spatial resolution, and you need a current between 1 and 50 milliamps. So it's pretty something that you have to apply. If you would do it on the surface, it would just hurt, and it would not reach the target where you want to have it. So it's not precise enough.
All right, thank you.
Okay, so one last question. I think it was in the first row, and then we will move on to the next speaker.
Could you elaborate how you filter out the artifacts from the EEG signal, specifically the muscle signals?
It's an adaptive filter.
Okay, so you can actually isolate the muscle signals and then subtract them, I guess. Oh.
Yeah.
Okay, thanks.
All right, thank you very much.
Thank you.
The next talk we will hear is from Mr. Patrick Heidinger, the CEO of 5Square. He comes in with a home advantage because their company is very near to our university, and he will give us some insights about sensor networks in the medicine area.
Hello, do you hear me?
Works.
On. Is it better now? Yeah.
Please welcome Mr. Patrick Heidinger.
Thank you, and thank you for the presentation early on. I mean, it's very hard to have a presentation after those presentations. That was very great. Thank you for the introduction. My name is Patrick, and I'm here from 5Square. I'm the CTO, but that's okay for me too. I would like to tell you something about censoring the future, or sensing the future, predictive networks, sensor networks to be exact. One moment. Yeah. we are Phi-Square. Phi-Square is, as you said, very close up here, like 100 meters behind the Mensa, where the parties are, like tonight. And our goal or our mission is to bring artificial intelligence or the technology behind artificial intelligence to our customers. And typically we are working with the industry sector, companies all around Austria, actually now also in the US to be exact, and we help them implementing those technologies in their processes and in their products. So we take this technology and try to make as much impact as possible at our customers. We are currently like 25 people working very hard on those projects, and next to the, I think I'm very loud, right? Yeah, okay. I hear myself, so. Next to those projects with our customers, we are also working on some research projects with the JKU and also with the RISC in Hagenberg. And one of those projects is, for example, AIMS. AIMS is a project where we would like to reduce the amount of people dying unexpectedly following by a routine surgical procedure, whereas these are 4% of all people, and that's unexpected. That's not the people who may be expected to die after a surgical procedure because they're old or very badly hurt, but those are unexpected. And in this project, AIMS, Artificial Intelligence-Based Monitoring and Early Warning for Patient Safety, very short name, where we are working on with the RISC in Hagenberg and the JKU Kepler University Clinicum, the Cook. We try to improve or reduce the amount of people dying. And this we would try to do by predicting if conditions are getting worse or better for the patient. After patients are coming back from the OP, in the normal station in the hospital, and there is no real monitoring going on. On the ICU, on the intensive care unit, there is a lot of monitoring going on, but those people are dying so rapidly that there is no real time to react, and that the doctors are not able to do anything for them. Because, for example, there is only one measurement of your blood pressure per night, and that's very little. So the permanent monitoring and, of course, condition checking is very important there. Oops. And another project that's about epilepsy. We already heard a lot of it. Our project is called Epilepsia, to be exact, where we would like to predict the next seizure. The goal is to improve people's life drastically, because people with epilepsy cannot, for example, drive with their cars because it's very dangerous. You can suddenly get a seizure and can't control your body or your brain anymore, and that's, while driving a car, not so great. And also, driving with your bicycle is a problem, and go swimming is a problem because, maybe some of you knows epilepsy from movies or so, and mostly they are tonisch-klonische Anfälle, seizures, and they are usually shaking very much. And for predicting those seizures, a very important point there is to collect the correct data and the data you need for this. And therefore, we are using sensor networks. We are building so far and evaluating which sensors are the best for predicting those diseases. To get one step back, artificial in healthcare is nothing new. Actually, I don't know. I studied I heard the first supervised techniques course like 7 years ago or so, and Sepp Hochreiter also already there told us about, for example, computer vision algorithms predicting skin cancer or cancer in your body. But why is AI not used more often in hospitals? And a very central element is that, it's expensive, data privacy is a big problem, ethical issues are there, but the very big problem behind all of that points are that there's simply too less data. You need a lot of data to, first of all, train your artificial intelligence or your algorithms, and then you have to validate. You have to prove that the algorithm is working properly in every single aspect. So it's very hard to do that, of course. And the central element we are facing also with epilepsy and AIMS is to get as much data as possible. And that's a very central element, or central question actually. How do we get data? And what data actually is needed, but that's the thing with how to get data. And one of those sensors, of course, could be our GTEC sensors. We didn't know them, so we didn't use them. That's bad, but we used a lot of other sensors. And yeah, in our case, sensor networks to be exact, because epilepsy is very hard to predict actually. With EEG, it's possible. There are a lot of studies going on, and actually many universities already showed that it's possible. But now the goal is to not use EEG, what you always have to wear while swimming. It's hard, and it's not very practical overall, or not always very practical. So the goal is to predict epilepsy while having, for example, only a smartwatch on your body. Yeah, and to reach this goal, we created a little framework for all of our projects to firstly collect a lot of data. It's very easy. I mean, I think most of you are technicians. So on the left side, you have sensors. You put the sensor on your body. Those sensors you would like to, what are capable of measuring your data or your vital parameters you need. Then you send those data to a gateway. I don't know, it's your smartphone, it's maybe some Bluetooth gateways or stuff like that. You send those data to your data storage. Data storage is in this case very crucial because security, GDPR concerns, and of course, actually, depending on which kind of sensors you use, there are sensors sampling up to like 10 kilohertz or stuff like that. And that's actually quite a bit if you are monitoring a lot of patients over a long time. Then, of course, data pre-processing. You have to use the right data at the right point. And of course, if you like, for example, predict epilepsy like 2 minutes in the future, you have to really synchronize your data or your data from different sensors, because if they are like 5 minutes apart, it's very hard to predict 2 minutes in the future. And another very interesting point is the user interface. You have to give every stakeholder exactly what this stakeholder needs. A doctor needs other information than, for example, a nurse. And a nurse needs other information like a patient or a technician. I just want to go into very short detail in each of those points, because I think afterwards we get the beer and the time is running fast. And yeah, just to shortly go into detail for data storage. Data storage is actually only at the time series data points a challenge. We are using mostly InfluxDB because it's fast and cheap and good. But actually, time series data is a little bit tricky. What the technical data, for example, metadata about your patients, etc., you can actually use every database you need, you like. We are using MongoDB because it's hip. I don't know. Exactly. Yeah. But at your real-time data insights, that's actually a point what is somewhat, or actually very important. The central element of when you're doing studies with patients and with real humans is that you have to be as efficient as possible. Not in terms of money, of course, in terms of money too, but in terms of you are producing or you introduce work to nurses who have no time at all. They're already very overworked. And also, if a patient have to wear a lot of sensors, it may be uncomfortable. And so you influence in a bad way the life of people, and that's something, if you do it, you have to do it only in a way that it's minimal and to get the highest quality data as possible. So getting good data is important, and losing as less data as possible is also very important. And this is, for example, very important. Central point is to detect sensor failures very early, to detect data drifts if a sensor is getting damaged or stuff like that. So you can detect it very early and change it. Yeah, and of course, anomalies if a patient is a sensor not working, for example, because they have too much hairs or stuff like that, you can either change it so that the sensor is working better, or just remove the sensor, because then it's less work for nurses, for doctors, and also for the patient. It's better. After you collected a lot of data, actually 80% of the work is done. Michael Kilitzliner said this on Thursday, and in my opinion, using AI or the algorithms afterwards is the more stable thing at this point, actually. You only, I don't know, go on Hugging Face, download your pre-trained model, even for medical data, put your medical data into the model and hope it's working. And if it's not working, just go back and collect other data and improve your data. And that's actually the point with enrichment, to really optimize machine learning models. The data has to be quite perfect, especially if the tasks are very hard. And to predict epilepsy, it's very hard. So the data has really to be very perfect, especially if you cannot rely on, for example, EEG data. Exactly. And of course, if you have the data and data labeled, just go find some pre-trained model from any university or study groups. There are usually pre-trained models. Use this pre-trained model, use your own data, change the models accordingly to your own data, and train them. You do not have to do anything from scratch anymore. And always keep in mind what you actually would like to predict. For medical things, actually the false negative rate usually is the most crucial part, because depending on what you like to predict, if you would like to predict if he's ill or not ill, but if you would like to predict he's not ill or he's not dying or she is not dying and have a big false negative rate, it's very stupid. And vice versa, if you have a big false positive rate, it's also not good, because if you tell the nurses or the doctor every 5 minutes, hey, he's going to die, yeah, you know what happens next. Yeah, and what a point I already mentioned is the user interface. Usually, especially from backend developers, it's not the most important part, but this is the only thing your staff, the clinical staff, the technicians, and also the patients is seeing next to the sensors. So if your user interface is not showing the right data for the right persons, it's not really be used, and in this case, yeah, it's not helping at all. And actually, especially in the hospital sector, there is a lot of there is a lot of stuff going on, and the people are very overworked and do not need more work. And if you make the world better for them, it's good. And you and if you make their world worse, it's very bad. And actually, they stopped the study, and that's a thing you really don't want to have. Yeah. So to keep it very short and simple, because of the time, the part or our part or what we are doing is, if we doing such project, the point is always to have a positive impact on the patient in the long term and also in a short term. So while being in hospital, we have to do everything that their life is not affected in a at least bad way as possible. And on the other hand, to our goal with every project, that's a mission from 5SK actually, and not from studies at all, and in general, is to use this technology in a way to help as much companies as possible and also as much people as possible. And we are doing a lot of projects in the industry sector, and it's very nice to improve a machine like for 5%. It's great, and it's actually really good for economy standpoint, and there's a lot of money. But actually, the most important part for us is if you can use this technology and affect people's life in a positive way. And that's actually some very central point for us, because most of us are coming from research or university fields, and we know what this technology can do. And actually, we also know what kind of technology is coming to our customers and to when there was our customers, so to say, what technology is used in the economies. There's a big gap. And this gap we have to close, and that's our mission as FiveSquare. Yeah. Maybe 2 words about me, then beer. Yeah, right. I also studied here at the JQ. I studied computer science, then artificial intelligence, and in life science. And I founded FiveSquare with Hans-Peter, who is the CEO, like a few years ago, and we are currently working on very interesting projects. And a very central point, yes, this is, by the way, my LinkedIn if someone wants to connect. And a very central point is, if here is someone who would like to help us improving the world, and a little bit at least, and use this technology to help people and companies, of course, we would really like your applications, of course. And yeah, we are open for any application, actually. So with this, thank you for your attention, and I'm open for any question.
In the case of the epilepsy project, what kinds of state-of-the-art models are you using for the prediction?
It's not only one model, because we are using many different sensors, starting from Bewegungssensor. Movement sensors, yeah. Movement sensors over EEG, not EEG, ECG, muscle movement and smell and stuff like that. Coming from the epilepsy dog. And for each sensor, we are using a feature extractor, a model, extracting us a high-level representation of those data, and then collecting those data and train a model predicting when and in which time span epilepsy seizure will be. So many different models for each data point. There are existing models you can just use.
So it's like there are multiple stages in the prediction?
Yeah, actually it's some kind of ensemble. You have for each, not for each, but for a few collection of sensor values, model, and connect them together, and then train one big model on top of it.
Okay, got it. Thanks.
What what amount of data are we talking in the measuring streams? Because we had the question with Mr. Guger as well.
Depending on the sensor, of course. For example, if you have a temperature sensor, you don't need 100 kilohertz. Like there's 1 hertz more than enough. If you have, for example, ECG or FNIRS or PPG sensors in your ear, for example, they're sampling with, I think, 10 kilohertz. So there is a lot of data, and it's very depending on what sensor you're using.
Thank you.
So, given then you find that the epilepsy is going to happen, is there something more you can do than just put a notification? You're gonna experience it.
The thing is, epilepsy is not really predictable, and what was not predictable. And if you're riding your bike, and you know it 5 minutes before you have an epilepsy and seizure, you can stop your bike and sit down.
Yeah, okay.
So it's very valuable to know it.
But there is not a way to somehow stop the seizure.
Actually, there's a lot of research going on with big pharma companies who are currently trying to find drugs to directly acute drugs, like you take it and the seizure is stopping. And also there's a lot of brain stimulation stuff going on and research going on. So yes, it is valuable, and you can maybe stop the seizure before it's occurring. And that's actually, you can think like diabetes. You find out it's not working. You take the drug, or you get the drug with a little pump, and it's never happening.
Oh yeah, thank you. That's what I was wondering, if something like that is possible.
It should be possible very soon.
A question from my side is: did you already found some combination of sensors or features you would think they are very promising to predict some cases? My thought is about doctors are more professionals, and so they would like to understand the results from you.
Exactly.
I assume. So you have to explain them. So I think they would not be happy if you say, okay, it's a combination of some features. We don't really understand the model, but it says the future, but we don't really understand. So do you have already a result of promising features?
I mean, that's a very important point. Actually, if you think a step further for certification steps, you also have to know what actually is happening, and you have to prove then that it's always working with data and that there is minimal bias. So yes, that's very important. To your question, we have parameters where we are actually right now in a big study with a few hundred patients, from children to adults. And currently, yes, there are features which are working very well. And yes, it's very important, and that's why we are working with doctors, to also bring this information back to the doctors so they can validate it, look if that actually can be parameters which are really in combination with epilepsy, and then it's also easier to get a medicine certified product. Yeah.
In the beginning, you mentioned it would be cool to predict, for example, a seizure with a smartwatch or something like this. Are you doing already experiments with consumer-grade wearable sensors, or just high-end medical sensors?
That was actually one of the most important part for us. We know a clinical EEG is capable of detecting epilepsy, and the next seizure within the next few minutes, actually. But a clinical EEG is not very comfortable to carry around when you have to take your big computer with you. And that's why we are actually testing with a lot of consumer hardware, because smartwatches, for example, have the big problem: if you're moving, it's not working very good. So to already have these problems in your data, we're using a lot of consumer hardware actually to find out if it's even possible with consumer hardware, because while having a seizure, you're usually shaking very much. So if your smartwatch is not working, it's not very good.
Okay. Thank you.
Like, I don't know how realistic this is, but let's say these consumer devices do not work as seizure predictors, are maybe a little bit more invasive methods like brain implants a better solution?
Yes, actually.
But are they already implemented as such for consumers?
No, actually there are implemented EEG devices, for example, and you can predict epilepsy with them. But you have the problem, you have to implement EEGs. So it's...
Yeah, but as a patient, right, is this just for research, or do patients actually get this?
I don't think there are... I don't know. I think there are people having implanted EEGs, but that's not common, to be honest.
Thanks.
How do you communicate the reliability of the technology you develop? I mean, in the seizure example, if you give a seizure patient such a device and tell them, go ahead and ride your bike, and you yourself know that it sometimes it works, sometimes it doesn't, and we all have, perhaps with ChatGPT, experienced this situation where the AI performs well in the easy examples, and you gain confidence that is unwarranted when you change the setting somehow. And how do you effectively communicate how reliable what you created is?
That's why we are currently in studies. We are in a clinical study, so we test a lot of different variables. And those patients, and you're right, are currently have radius like 10 meters. They can go to the toilet and back to the to the desk and to the bed. And yes, there is no real data regarding riding a bicycle. And yes, we are not able yet to tell them if it's working then too. We test, of course, movements and stuff like that. So we see artifacts and try to handle them, of course. But to prove that those sensors are working while riding, while driving a car, while swimming, is the next step. After we actually focused on one sensor network, or on one sensor ideally.
Thank you.
That's maybe a mean question, but I think I know that some patients know when a seizure is about to happen. Do you know any advantages regarding that? Is your device like faster or more reliable than the feeling of the patient?
Actually, not many people know that they are getting a seizure. Usually it's more their parents of children that know that their seizure is coming, or epilepsy dogs. But actually, the other way around, it's more common. People do not know after they had a seizure that they had a seizure. Actually, it's the way that drugs are very, very strict to if you have 3 seizures per day, it's very different than having 5 seizures per day, and also how much drugs you have to take. And so most patients do not know how many seizures they had in one day. And how can you then select the right amount of drugs? And so not only the prediction is very important, but also only to detect if there was a seizure or not is very, very, actually is a huge benefit for doctors and clinical staff. And that's why the patients are on the EMU, on the epilepsy monitoring unit, to count how many seizures per day were there.
And maybe a bit of a general question. I know that big hospitals have their own databases with a lot of data. You as a company, where do you see your place in comparison to them, because they also doing a lot of AI research?
That's true. First of all, we have one sensor nobody else had so far. That's smell sensor, because the epilepsy dog, usually it's the smell with dogs, especially with insulin, for example. And we also hope for epilepsy. And actually there are studies suggesting that epilepsy dogs smell it, because they took sweat from the skin before there was a seizure, and dogs had like 99% or so on those probes. So the smell could be very important, and if the smell if it's the smell, you also can design sensors on the skin. I'm only taking those molecules what are really responsible with or in correlation with epilepsy.
Very interesting. Thanks.
All right, one last question, and then we will go drink a beer.
Great.
So my question would be, could you also apply your technology to rather psychological illnesses, like, to predict if there's a depressive episode or a panic attack, or, I don't know, some aggressive episode? Criminals, for example?
Actually, around epilepsy, there are many diseases very similar to epilepsy. For example, Alzheimer. For example, I don't know the English word fever, Fieberkrämpfe. Fever, I don't know. And those diseases are very similar to epilepsy, and we hope, ideally, that we can use this data actually and transfer it there. If it's not working, we take our sensor network and search for the next disease. And that's also a very important thing, or in every study actually, there is a small research project going on to, for example, synchronize data points over sensors. And it's very unscalable because everybody does the exact same thing again and again and again for every study. And we are created the framework to greatly reduce this work because there is a standardized framework collecting data. And AIMS, what was the second research project, is now way less work to do than epilepsy, for example, because the whole framework was there. And we can take this framework and bring it to the next problem.
Okay, thank you.
All right, so in summary, for me to understand, one last question. One more is separating us from the beer. You are basically trying out different sensors and different and see what is viable. And then you have to still collect a lot of data. How are you going about collecting the data from all the different sensors?
This is exactly what I showed earlier. We have infrastructure in the hospital on the EMU, on the epilepsy monitoring unit, where we collect all the sensors, the data from the sensors, synchronize them, predicting training models on the data. Then I'm selecting sensors, what are the most promising sensors. And the next step, and this will start within the next few months, to produce a sensor or to find a sensor what is capable of collecting exactly this data, so as small as possible, with a battery long enough to last the next 20 years, you know. And if we found the perfect sensor, or we built the perfect sensor, we go back and try this sensor at our patients and find out if it's still working. And if it's still working, we have to find out if it's always working. And then we have a medical device, what is hopefully not only theoretically helping people, but also practically helping people.
Amazing. Thank you very much. And also thank you very much, everybody, for coming to this event. We will now head down to the Sparkasse JKU. We will drink some beer, and if somebody does not want beer, we have some anti-alcoholics as well. Just talk to each other, have a nice time, and then maybe we'll see you at the next event. Thank you very much.